this is my first slide. Primary mitochondrial disease as a heterogeneous group of energy deficiency disorders with pathogenic variants in either mitochondrial or nuclear DNA. And then again, discuss just, there are 16 various symptoms on average from anything in these patients. The symptom time of onset can range from infancy to late adulthood and can involve either a single organ or severe multi-system failure. So when we talk about autonomic dysfunction and PMD, it's thought to occur in as many as 38.5% of children with definitive or suspected PMD. But the specific features are not well described in the literature. It's mostly in adults and mostly in single PMD disorders. So, very highly described in a specific disease. So we came up with the DySSy, the Dysautonomia Symptom Survey, as a questionnaire to assess both the features and severity of these symptoms. We felt, or what we did was we counted symptoms that occurred at least weekly as affirmative. And then I was kind of getting into the issue of the Compass 31. So one of the things that came out in the latest American Autonomic Society meeting is that a lot of people have used the Compass 31 to assess autonomic dysfunction in a variety of disorders. And that includes things like POTS, diabetic neuropathy, scleroderma, and I'll actually show some of these a little bit later as well. But Wolfgang Singer, who was one of the folks who was originally involved in the creation of the Compass 31, reminded us all that it's really only been validated for autonomic neuropathies and synucleinopathies. So I think we just have to make sure that we keep this in mind. Our patient sources were both children and adults. And we got 4 different groups of patients. The Children's Hospital of Philadelphia Mitochondrial Medicine Frontier Program, or the MMFP. And within the MMFP group, we had 2 different subtypes. We had those who were genotype confirmed, or PMD positive, and then we had patients with suspected PMD, or what we referred to as PMD negative. And then we also went outside to see the United Mitochondrial Disease Foundation Mitochondrial Disease Community Registry, or the MDCR. And again, we split these patients into 2 groups, those who reported that they were genotype confirmed or PMD positive, and those with suspected but not confirmed PMD or PMD negative. And our statistical analysis was used here. One thing that to keep in mind was that we did use a Bonferroni correction. And so our threshold p-values were a lot lower than just typically 0.05. And the reason for those that are not familiar with using a Bonferroni correction is if you ask a lot of questions, then your likelihood of getting a positive answer is higher, but that positive answer may not necessarily be statistically significant. So one of the ways to correct for this is to divide your threshold value for significance, 0.05, by the number of questions that you use. And that's what the Bonferroni correction does. When we were set our Likert analysis for quality of life, we split out excellent, very good, and good versus fair and poor, much better, somewhat better versus somewhat worse and much worse. And then some of the time, a little of the time, none of the time versus most or all of the time. And then we did multiple comparisons. You're going to see a lot of initials. And so hopefully I'll be able to help you kind of maintain a little sanity with this. So to remind you, the MMFP is the internal, or the CHOP group. The MDCR is the external, or the United Mitochondrial Registry group. And again, PMD positive or those patients who were genotypically found or reported in the MDCR case to have primary mitochondrial disease, and those who were PMD negative were either genotype negative or suspected. So we compared within MMFP, the PMD plus versus minus, and the same for the MDCR. And then we also went between groups, MMFP versus MDCR, in our PMD positive and negative groups. And then we also compared those who were specifically PMD positive in children versus adults. So let's talk about what we found with the kids first. Here's our demographics. As you can see, not a huge study, not a huge number of respondents, 49 in the MMFP group, 31 in the MDCR group. And you can see the age distribution here. Interestingly, I think one of the things that's kind of interesting is here specifically is that the MMFP group has a lot of kids under age 3 years. That may be potentially because the MMFP is just either diagnosing it sooner, or patients are not getting to the United Mitochondrial disease group until maybe they've been diagnosed later. You can also see our breakdown between PMD plus versus minus patients, as well as the location of the genetic variant. And it's almost split. Half of them are mitochondrial, half of them are nuclear. So this is what we found. There was no difference in the frequency of specific symptoms between any of the PMD positive, PMD negative, MMFP, or MDCR groups, and we sort of assessed all of them in different directions, and there were no statistically significant differences. I think the reason for that, though, and as I go over the specific symptoms, you'll see a range of percentages of occurrence of these symptoms. And that's probably because our sample size was relatively small. But some of the things that you can see here in the patients, nearly half were able to perform mild exercise, which means about half were not able to, okay? There was a wide range of patients who had skin color change, and a quarter to a half of them had heat intolerance. There was a range for patients having brain fog and insomnia as well. I think the other thing to keep in mind is look at the tachycardia, skipped beats, and orthostatic symptoms. Those are relatively low, and certainly much lower than we would expect as compared to patients who have postural orthostatic tachycardia syndrome. Other symptoms that were found included a fair amount of GI symptoms, early satiety, bloating, nausea, abdominal pain. Very little issues from a bladder standpoint. There were some aspect of pain and nerve pain, and very little ocular symptoms. When we looked at the overall number of, or the overall amount of symptomatology, anywhere from 3/4 to 100% of patients reported any symptoms. 1/3 to 2/3 had at least 5 symptoms, and then very few had at least 10 symptoms or at least 15 symptoms. And the reason I bring this up is I want you to compare this to the next slide, which is what our symptomatology that we published in our demographics paper in 2018, which was a study of our pediatric POTS database. And at that time, it was over 700 patients, where 2/3 of patients reported at least 10 symptoms, half of patients had at least 14 symptoms, and 30% reported over 26 symptoms. So much lower overall symptom reporting. When we looked at the quality of life findings. In the MMFP group, 3/4 of PMD positive patients really had a positive quality of life, as compared to about 41% of the PMD negative patients. And that actually turned out to be significant. Otherwise, there was no difference between groups in their change of health. Over 3/4 of them felt that in the last year, their symptoms were either the same or better. Up to 2/3 felt that there was minimal interference with their activities of daily living, and almost 2/3 felt that there was minimal interference with their social activities. When we looked at the MBCR group, they also had up to about 2/3 of them felt like their general health was good, and 3/4 to 100% of them felt that their change of health in the last year was the same or up to better. Almost half, though, felt that there was minimal interference with their activities of daily living. So they did demonstrate more interference with activities of daily living, and as well as, although their interference with social activity was relatively minimal too. Then we looked at the Compass 31, and to remind you, it's a 0 to 100 score, with a higher score meaning being more affected. So we broke it out by domain, and there were really no significant differences between MMFP and MDCR in the orthostatic, vasomotor, secretomotor, GI, bladder, and pupilomotor scores. Although one of the things to look at overall is how the GI scores are much greater than the other domains. And then total scores were relatively low, 10 to 17 for the MMFP and 16 to 33 for the MDCR groups, which would be essentially mild impairment. When we looked at bivariate analysis, there was no differences in GI, bladder, or eye symptoms between groups. So from a summarization standpoint for the pediatric findings, there were really no differences when comparing the MMFP groups with the MMDCR groups, or the PMD positive or negative groups. They had an overall symptom burden versus POTS that was lower. They had more GI and temperature intolerance complaints with fewer cardiovascular symptoms, but they did demonstrate some aspects of pain, brain fog, and exercise intolerance. Their quality of life was overall good. And their Compass 31 scores were relatively low and mostly demonstrated findings in the GI domain. All right, now for the adults. So here is our demographics for this group. A lot more adults in the MDCR group. And again, you can see the breakdown of PMD positive and PMD negative, as well as their genetic locations. Interestingly enough, a lot more patients with mitochondrial DNA variants than nuclear DNA variants in the adults. When we compared the PMD positive and negative groups, there were no differences in symptoms on the DySSy in the MMFP group. However, in the MBCR group, there was more skipped beats in the PMD positive group, and in the MMFP group, when we compared PMD positive versus MDCR PMD positive, there was more insomnia in the MDCR group. Looking at specific symptoms, again, relatively lower overall cardiovascular symptoms, but a higher amount as compared to the pediatric patients. Again, about only half were able to perform mild exercise. And a significant amount of heat and cold intolerance. Again, brain fog and insomnia are seen here, as well as some headache. Also, again, GI symptoms. There's more findings from a bladder standpoint as compared to the kids, as well as the ocular standpoint, and a lot more pain. Paresthesias, arthralgias, and myalgias are also seen in the adults as compared to the kids. When we look at their overall symptom reporting, 86 to 100% had any symptoms. And then up to 83% had at least 5, almost half had at least 10, and then a small amount had at least 15 symptoms. So again, this is a greater amount of symptomatology or symptom reporting as compared to pediatric patients. And in the adults, the MDCR patients had more symptoms than the MMFP patients. And the PMD negative patients, so those who did not have, who had suspected but not confirmed primary mitochondrial disease, had more symptoms as compared to the PMD plus patients. When we looked at quality of life in the MMFP group, almost half felt that they had, so there was no difference between the PMD positive and negative groups. Almost half felt they had very good, very good, or excellent general health. About 3/4 of patients felt their health in the last year was much better, somewhat better, or the same. About that same amount felt that there was anywhere from none to only some interference with their activities of daily living. Up to 1/3 were told that they were making up their symptoms, and a little over 1/3 were told that their symptoms were all in their head. When we looked at the MDCR group from a quality of life standpoint, the PMD positive group had a 44% demonstrated excellent, very good, or good general health, versus only 14% of the PMD negative patients. And yet this was still less than half of patients. So these patients definitely had more of a negative impact of their mitochondrial disease on their general health. And then the rest of the groups were no different in their change in health, their interference with activities of daily living, interference with social activity, and then a little bit less than half were told they were making up their symptoms, and about half were told that their symptoms were all in their head. So looking at, just getting back to the interference with activities of daily living and the interference with social activity, most patients felt that there was insignificant interference with these two issues. Looking at the Compass 31 findings, the scores by domain were no different between MMFP and MDCR, except in the GI group. The MDCR patients had a significantly higher score than in MDCR than MMFP. But I want you to also look at the orthostatic scores. If you recall from the pediatric patients, those were much lower, and now the adult patients are reporting more orthostatic symptomatology. They're also reporting more bladder and pupillomotor symptomatology. So when we look at their total scores, whereas the kids had the lower scores, and I'll do a side-by-side comparison in a bit, the adults with Compass 31 had definitely demonstrated higher scoring here. And again, bivariate analysis showed no differences between GI, bladder, or eye symptoms. So now, This is a graph demonstrating comparison between the blue is healthy controls, red is small fiber neuropathy, green is diabetic neuropathy, purple scleroderma, blue is fibromyalgia, and then the orange is looking specifically at adults who were in the MMFP program and who were PMD positive. So this is comparison with published data from several studies that you can see down in the lower right corner. And overall, you can see that the MMFP patients, or the PMD positive patients, scored pretty similarly to, from a Compass 31 standpoint, to these other disorders. So what was felt to be statistically significant from an orthostatic standpoint was the healthy controls were less. In the vasomotor scores, the scleroderma patients had more. And by the way, the PMD score there was 0. So that's why you're not seeing a bar for the PMD plus folks. In the secretomotor patients, everybody but except the healthy controls and PMD positive patients were felt to be significant. And then you can see the breakdown from a GI, bladder, pupilomotor, and total standpoint. Total score standpoint. So now we broke this out looking at pediatric patients versus adult patients with the DySSy. And we combined the MMFP and the MBCR patients, but used only the PMD positive, right? So we used the CHOP and the external patients, but only those who had confirmed or reportedly confirmed mitochondrial disease. And when we looked, we found that the adults had statistically significantly higher scores from an orthostatic standpoint, from a headache standpoint, from a brain fog. They had more brain fog, almost half of them had brain fog. Myalgia, xerophthalmia, and blurry vision. All the rest were not considered to be significant, but again, you can see the relatively low numbers, so it's more difficult to discern a significant difference. And then in symptom reporting, the adults again had higher groups of patients with at least 5 symptoms and at least 10 symptoms. When we compared them side by side with, from a quality of life standpoint, for general health, it was right at the level of the threshold of significance for the pediatric PMD positive patients, having about 2/3 of them versus a little bit less than half for adults feeling that their general health was excellent, very good, or good. For the pediatric patients had a change in health over the last year that was significantly improved, 3/4 of them versus a little over half. There was no difference between their reporting of interference with their activities of daily living or interference with social activities. But interestingly enough, adults were much more likely to be told that they were making up their symptoms or that their symptoms were all in their head. When comparing the Compass 31 scores, and again, you can see the corrected p-value threshold at the bottom, adults had a higher orthostatic score, higher secretomotor score, higher pupilomotor, and higher total score. So when looking at the adult findings, they had higher overall symptom reporting versus pediatric patients. Most patients had at least one symptom, but still a lower overall symptom burden versus versus at least pediatric patients with POTS, as listed before. But truthfully, if you look at the paper written by Shaw, the face of postural orthostatic tachycardia syndrome, Lauren Stiles is also a co-author. That symptomatology is fairly similar as well. The MDCR patients and the PMD negative patients reported more symptoms than their counterparts. They had mostly exercise intolerance, temperature intolerance, brain fog, and pain. They did have moderate GI and some orthostatic symptoms, and they had more bladder and eye symptoms as compared to pediatric patients. They still had a relatively good quality of life, though slightly lower than pediatric patients. And from a Compass 31 standpoint, their impairment was low to moderate. They had higher scores, which was worse than pediatric patients, with higher orthostatic and GI domains as compared to the others. And this appears to be comparable with other autoimmune disorders with recorded autonomic dysfunction, with the understanding, again, that the Compass 31 is not validated for these disorders. So you can ask, why are the pediatric symptom scores lower? And there could be several reasons for this. Children may not report their symptoms. The parents may not notice the symptoms as much. Adults might just catch more, and that might just be that they're more aware of their bodies. They're more aware of themselves, and this is something that we see a lot in pediatric POTS patients, where they're not necessarily as aware of some of the symptoms that might be abnormal. The other thing too, I think, to keep in mind is with mitochondrial disease, there may be some aspect of cumulative deficit in adults that children just don't have. And obviously this depends on the mitochondrial disorder or the nuclear DNA disorder, but this might be something that could factor in here as well. I think one of the other things to keep in mind is, do some PMD negative adults actually have POTS? And that may be, considering that they have more orthostatic symptoms. Certainly their symptom burden is probably less as compared to POTS patients, but this could still be something to consider. So in summary, patients with PMD have symptoms of autonomic dysfunction. Adults report more symptoms. Patients without proven PMD seem to report even more symptoms as compared to those who have proven PMD. The symptomatology includes more GI and temperature intolerance, brain fog, and pain. The pain is much more so in adults. Their quality of life is reasonably good, with children having a somewhat better quality of life as compared to adults. And the Compass 31 suggests low impairment in children and low to moderate impairment in adults. So this lets us know that providers really should be querying mito patients regarding symptomatology. Number one, just for the simple acknowledgement that these symptoms exist, and for validation that these symptoms exist and they're not just making them up. And also that there are non-pharmacologic and pharmacologic therapies available for some of these things. Something as something as simple as a cooling vest for patients with heat intolerance can make such a difference for them. And we know that obviously double-blind, that's serving double double-blind randomized placebo-controlled trials of therapies are certainly needed, not just in POTS patients, but also in these mito patients. And we do need to really better understand the underlying process in PMD that leads to symptoms of dysautonomia. Just wanted to acknowledge the folks that I've been working with at CHOP, including Marnie Falk, Ed Shadiak, Elizabeth McCormick, Laura McCullen, and George. All right. That's it, folks.
Thank you so much, Jeff, for the really interesting talks.